Thank you. Good morning. It's a privilege to be presenting our study today. I'll be discussing findings on early outcomes of heart transplantation using donation after circulatory death donors in the United States. These are our financial disclosures. Heart transplant using organs donated after circulatory death, or DCD, has had a resurgence in the U.S. since 2019. This has the potential to significantly expand the volume of heart transplants performed in this country and elsewhere, and encouragingly, estimates have shown that this could be a volume expansion of over 20%. This could be the largest potential expansion in the modern era of heart transplant. However, there is limited data to assess the safety of DCD heart transplant, and so the aim of this study was to summarize recent trends and outcomes of DCD heart transplant in the U.S. The complexity of DCD heart transplant lies in the obligatory warm ischemia period during procurement. This begins after the withdrawal of life-sustaining support and the onset of deteriorating hemodynamics, which then progress to circulatory death. There are two procurement strategies which attempt to mitigate this potential warm ischemic insult, one of which is direct procurement and perfusion, or DPP, and this is frequently paired with ex vivo machine perfusion of the organ. The second procurement strategy is normothermic regional perfusion, or NRP. In NRP, extracorporeal circulation is rapidly established in the donor, thereby reperfusing the heart, reanimating it in situ, and after a period of reperfusion, the heart can be assessed and then procured if acceptable. Both of these strategies have recently been adopted in the U.S. This study utilized the UNOS registry, which captures all transplants performed in the United States. We identified all adult heart transplants from 2019 to 2021 and excluded any multi-organ transplants. Patients were grouped according to conventional transplant using organ donation after brain death, or DBD, versus transplant using a DCD donor. The primary outcome was 1-year mortality, and we performed propensity score matching to create well-balanced cohorts and multivariable models for risk adjustment. Finally, we performed a sub-analysis comparing DPP versus NRP procurements in the DCD group. In total, we identified 7,496 patients undergoing isolated heart transplant in the study period. 229 patients, or 3% of the study population, received DCD organs. There's a positive monthly trend in the volume of DCD heart transplant from 2019 to 2021, and in the last year, DCD heart transplant accounted for over 6% of all heart transplants that year. In addition, the number of centers performing DCD heart transplant has grown from 3 centers in 2019 to 20 centers by late 2021. Comparing baseline characteristics, recipients of DCD organs had a higher median BMI, and they were more likely to be mechanically ventilated or admitted in the ICU at the time of transplant. 14% of DCD recipients were bridged with temporary mechanical circulatory support devices, compared to 38% in the DBD group. However, DCD recipients were more frequently bridged with durable LVADs at 40% compared to 29%. DCD recipients also had a lower priority listing status and were primarily listed as status 4 at the time of transplant, compared to DBD recipients who were primarily listed as status 1 or status 2. DCD recipients did have a significantly longer waitlist time, with a median time of 47 days compared to 32 days. Go back there. Regarding donor characteristics, DCD organs had a longer median travel distance, and DCD donors were significantly younger at a median age of 29 compared to 32. DCD donors were also more commonly male and white. And finally, DCD donors were more frequently sex-matched to their recipients compared to DBD donors. On Kaplan-Meier analysis, unadjusted 1-year survival after heart transplant was similar at 90.8% among DCD recipients compared to 90.4% among DBD recipients. After propensity matching, there were 224 DCD recipients who were well matched with close to 2,000 DBD recipients. There were no differences in baseline characteristics after propensity matching. In this propensity match cohort, 1-year survival was again similar at 91.1% for DCD cases versus 90.3% for DBD. On analysis of secondary outcomes, we detected an elevated rate of drug-treated rejection before discharge from index hospitalization among DCD recipients, both before and after propensity matching. There were no differences between DCD and DBD recipients in the rates of postoperative dialysis, stroke, or pacemaker placement, or in hospital length of stay, either in the unmatched or the matched cohorts. Finally, in looking at procurement methods for DCD transplants in the US, we found that DPP was the predominant strategy, representing over 80% of DCD hearts procured. Although performed less frequently, the use of NRP has increased over time and represented over 27% of all DCD heart transplants in 2021. 1-year survival was 92% for DPP compared to 97% for NRP transplants, which was statistically similar. However, the patient cohort sizes were small in the sub-analysis, and therefore the comparison was subject to type 2 statistical error. In conclusion, we found that rates of DCD heart transplant are increasing in the US, but despite this wave of early adoption, there's only a minority of transplant centers that are performing DCD heart transplant. We find that recipients of DCD hearts have comparable early outcomes to conventional heart transplant recipients, and this is consistent with the international experience with DCD heart transplant. However, we detected increased rates of early rejection among DCD recipients, and this requires further research and insight. Further analysis is also needed to establish whether there are any relative benefits to DPP versus NRP procurements. But given the findings from this current study, we conclude that broader utilization of DCD hearts is warranted, and continued efforts to educate non-utilizing centers are prudent. Thank you.
Very nicely presented. The invited discussant is Dr. Pedro Catarino.
Mr. President, members, guests, thank you for asking me to discuss this paper, which gives us the first real insight into the explosion of activity that has been the arrival of adult DCD heart transplant in the USA. Dr. Kwon, congratulations on your presentation, certainly worthy of this special presidential recognition which the abstract achieved. And congratulations on using the great resource which is the UNOS registry to show us a real-world picture of current DCD heart transplant in the US. This really augments what we've learned from the recently presented US DCD heart study, an industry-sponsored study looking just at the DPP technique, and presented 2 weeks ago at the International Society of Heart and Lung Transplant. And your study covers those DPP patients plus the extra NRP and is therefore the largest series of DCD heart transplants in the world literature. So I have a comment and then 3 questions which I'll pose one at a time. My comment is that from the first adult DCD heart transplant in the US in December 2019 until the end of your study period, September 2021, there were 229 transplants. As someone from Europe, where we have been going at this for 6 years and are well behind this volume, and certainly behind the intensity, I think this has really been a great success for the field and for patients, and I'm very optimistic for its continued growth and for the potential to answer the many questions which remain in this area. So my first question is, you chart the rise of DCD heart transplant, both in terms of a rise in overall volume and a rise in the number of centers undertaking the procedure. Were you able to identify a learning curve or a volume outcome relationship paralleling this rise? And does that have implications for the dissemination of the practice?
Thank you for your comments, Dr. Caterino. I think your question raises an important point. We have continued to get encouraging data regarding early outcomes with DCD transplant, and so that next logical step is addressing broader utilization and a potential learning curve effect with this practice. We heard from the Australian experience that they did have a learning curve effect with high rates of early PGD requiring ECMO support, which then declined with increasing center experience. We did not bear this out in our data. Of course, the outcomes that we can evaluate in the UNOS registry is mostly mortality and other secondary outcomes which we presented. And I'm not sure that mortality is the most sensitive indicator of a learning curve effect. We would love to be able to present data on the occurrence of PGD, but the UNOS registry doesn't capture this very well, and so we're not able to comment on that. I'll kind of close that out with a comment that I think would be very interesting to look at DCD donor utilization after procurement, because we know that DCD procurements can be logistically challenging and they're very time sensitive. And so they can, I think, be influenced by a learning curve with new centers adopting this new strategy. And that is data that's capturable, and I think that's ripe for analysis using the UNOS registry, and it'd be interesting to see.
Thank you. That's a very good answer. You noted in the study that there were a number of differences between recipients and donors in the DBD versus DCD. And I think the UNOS registry does allow you to see the different UNOS regions that the procurements have come from. And I imagine that in some regions there is just one center that has a monopoly of the DCD, whereas in some regions there are multiple centers and more competition. And I wondered if that allowed you to see whether there was a change in practice regarding donors and recipients who were accepted.
Yes, we are able to characterize sort of the volume by region and geographically across the U.S. We do have some centers that appear to be maybe high volume and monopolizing potentially a geographic area. UC San Diego, for example, has had very high volumes of DCD heart transplant, and there's sort of that one active center in that area of the U.S. Sort of a counterexample that I have is in looking at UNOS Region 11 in the Southeast, where we have the two highest volumes for DCD heart transplant in that one region and in neighboring states of North Carolina and Tennessee. And so they've been able to accomplish very, very high volumes for DCD, lead the country in those volumes, and I think they're just traveling very far to get these. We found that the median organ travel distance was almost 400 miles, and so I think there just aren't enough centers that are currently performing the DCD heart transplants in a way that we're seeing geographic competition yet, and I would not be surprised to see that happen in the future.
Okay, and finally, as you pointed out, there remains a lot of discussion about the optimal organ recovery strategy, so DPP versus NRP, and you essentially have the largest NRP series to date. So I wondered if you could give us any more granular information about the current use of NRP. In particular, I'm interested in if you're able to identify the warm ischemic time between the two techniques, and also whether you've got any data about the utilization of the heart and also of the other organs.
Yeah, I think that's a very interesting subtopic in DCD, is looking at the different procurement strategies. Of course, Papworth, as you know, has had some early data that is slightly favoring NRP procurements in terms of utilization and potentially patient morbidity and mortality, but the data is still very premature at this point. At a registry level, it's a little bit hard to really glean details into the particular practice of NRP. We are able to see, for example, the rate of ex vivo machine perfusion among NRP procurements, which was about 30%. So the majority of these organs are being transported in cold static storage, which that does seem consistent with what is reported in institutional series and in the practices that we know of in the U.S. The warm ischemic period is very important for DCD procured organs. And we're able to calculate that time for DPP organs. We're provided with a time of death, essentially, and a time of when cold cardioplegia was delivered. And so we just calculate the warm ischemic time between those two time points. For NRP, it's a little bit more obscure. In NRP strategies, the warm ischemic period is ended upon establishment of extracorporeal circulatory support. So you're on ECMO or bypass, and that time point is not marked in the UNOS registry. And so we can't really comment on a specific warm ischemic time period for those NRP organs. As far as, I think that last question, utilization. So that is something that I'd love to look at in the UNOS registry. It is possible to look at the entire set of donors who have been registered through UNOS and see which ones were pursued as DCD procurements and which ended up ultimately transplanted. And particularly in looking at procurement strategies, I think that'd be a very interesting study to do to see what the utilization rate was, but we did not include that in our analysis.
Thank you very much. Many congratulations again, and I'm sure your paper will stimulate other heart transplant centers to take up this important group of donors.
Thank you.
Thank you. Dr. Egan.
Tom Egan, UNC. Very nice presentation, and you outlined the underutilization of organs from controlled DCDs, not just hearts, but other organs as well. And I'm wondering if, because over half of Americans are registered organ donors, that is, during their lifetime, they said that upon their death, they wanted to be organ donors. Do we have an ethical obligation to honor that wish? And does that ethical obligation override the ethical issue of, the dead donor rule? All of these controlled DCDs die because we withdraw life support, and whether they die soon enough for their organs to be recovered or whether they languish and die later, if they wanted to be organ donors after their death, then maybe it would be reasonable to recover their organs, the way we do with brain-dead donors.
Thank you for that comment. I agree the ethical kind of conversation, especially regarding NRP, has been an active one recently, particularly when we're presenting results like this, and as we gain more data, if there is some relative benefit to NRP, I think we'll have to keep revisiting that conversation. I agree with you that a key stakeholder in this conversation is the donor family and the donor wishes, and there's a lot of stakeholders that need to be represented in that ethical conversation, which is a little bit out of the scope of our analysis, but certainly an important topic for our field to address.
Thank you. Okay, we're running a little short on time. Quick question from microphone 3 and quick answer.
Congratulations on your analysis. This was very good. I have 2 questions for you. One, how did you identify the NRP patients in the UNOS database, as this is not a variable? And something that is often overlooked in the UNOS database is the ascertainment bias and outcomes over the most recent 6 to 9 months in the data set. So how did you handle your censoring to account for that? Thank you.
That's a point well taken. So the NRP versus DPP procurement strategy is not a variable. It's something that we had to derive from time points, basically measuring the time from death to the delivery of cold cardioplegia flush, which should be rapid for DPP and is prolonged for NRP given the period of reperfusion on ECMO or bypass support. When we created a histogram of those times, there's a nice bimodal distribution in those times and a very nice separation of those two strategies, which we could, I think, reliably distinguish between DPP versus NRP procurements, but it is a derived data point. Regarding the survival bias, given the reporting at 6 months out for survival. We did exclude any patients that had incomplete survival data, but we are aware as we perform UNOS analyses of recent trends and kind of up-and-coming trends in transplant, that is a bias. We did have sort of equal follow-up time once we excluded those that did not have missing follow-up data.
Okay, quick question from two.
Sure. Can you tell us, firstly, who went to procure the organs? Was it the home team, or is there a specialist team? And then, obviously, as the explosion occurs in this procurement, who do you see? Should it be the center that is receiving the organs send out a team, or are there going to be specialists who procure it?
At a registry level, it's very hard to know that. I think the teams look very different depending on DPP and NRP and the equipment that you need to send out with that. We're not really able to comment on a detailed way from this registry analysis, however.
Thank you.